It looks like we're live. Rachel, is that right? We're live. Can you give me a
Yep, everything
thumbs
good.
up? All right, you guys. Well, welcome. My name is Hiva, and I'm here with Archer Review. I appreciate everyone coming to join us today to talk about do our pediatric live webinar series today. We've got a lot of ground to cover, so I'm going to go a little quickly, but it's going to be interactive. So keep your chat window open. We're going to ask some test questions, and you're going to get a chance to ask your questions as well. And our lovely Rachel is helping us with the chat today. So it's going to be fun. It's going to be quick, but it's going to be comprehensive. So with pediatrics, what I want to say before we get started is some of this might seem like common sense, and that's really good, especially if a lot of you are parents and you have kids of your own. You're going to understand and recognize some of these patterns based on your own experiences. Don't worry if you don't have kids. When I was sitting for my boards, I didn't have kids, so I had to learn all these things, but it will come naturally over time and it'll feel like second nature over time. So do not panic. It's going to come. You just have to practice a little bit. What I generally tell people is with pediatrics, try to, when you're reading the exam question, visualize that patient in front of you. So when you're reading the test question, visualize the age of that child, what that child looks like, how they're interacting in your office, and what those specifics of the test questions are going to relate to that visual that you have in your mind. So try to keep that in mind as we're going through some of these things. All right. So we're going to start with milestone screenings and vaccines, and then we're going to go into some common conditions that we see. And then I'll throw in some test questions in the middle there too. So pay attention. I know you're going to do great. So milestones, why are these so important? So pediatric milestones are the skills and abilities children hit at different stages of growth. So why are milestones important for us as clinicians? It's a way for us to make sure that the child is growing appropriately, so that if we notice a delay in the milestone, we can intervene early and get that child the help that they need early on. So the key with pediatrics is prevention, right? So we want to identify and help that child to prevent any issues down the line. So prevention is going to be really important. So those milestones, what are we talking about? You can sit down and look at the milestones and read through them comprehensively, but like I said, get a visual of that child in front of you. So 1 to 2 month old should be waking up, right? They're starting to give you that social smile or maybe a little gas smiles. You know, you can fool the parents and say, oh yeah, they're smiling at you, but they really should be starting to observe the world around them. So 1 to 2 months, they're observing the world. And then you really want to emphasize tummy time with those parents, because especially new parents, first-time parents, are going to be really freaked out. They're going to coddle that baby. They're not going to want to put them down, or especially not put them down on their belly, especially after everything we've read and heard in the news about sudden infant death syndrome. So making sure that you're educating those parents about tummy time is really important, because that's going to help strengthen those neck muscles for that child so that it reduces their risk of SIDS moving forward. And we're going to talk a little bit about that once we talk about SIDS. But you want to make sure that you're doing some education, some anticipatory guidance for those patients and those families, and getting that baby to do tummy time. Now, of course, they can't hold their head up the whole time. It's going to be really floppy. So you have to observe those babies. You cannot just leave them unattended. Don't worry, new parents won't do that. They'll be watching them, but get down on the ground with the babies. They hate it. Try to get some toys down there, make it interactive, and keep it short, light, brief, and fun. But definitely want to talk to parents about tummy time, get those neck muscles strengthened. By 2 to 4 months. They should have some better head control. They're starting to babble, right? They're hearing sounds, they're observing sounds, and then they're starting to mimic that. And a 6-month-old by then is probably sitting up, maybe still with a little bit of support, but should have enough muscle tone to be able to sit up, right? And recognizing familiar faces. So recognizing mom, dad, immediate caregivers versus strangers. Stranger danger comes a little bit later, but should start to recognize familiar faces around this age. The other thing I want to point out about these milestones is that the guidelines keep changing about when to start solids, but generally as a clinician, you want to look at the whole picture and start thinking about talking to your families about starting solids between 4 to 6 months of age, okay? And we'll talk a little bit about that once we get to failure to thrive, but you want to make sure that that child is growing along their growth curve, okay? So moving forward, 9-month milestone. So this baby's probably crawling, saying mama, dada, which, new moms and even more seasoned moms get really excited about. They're working on their pincer grasp. So you want to give them solids like Cheerios, not Honey Nut Cheerios, but regular plain Cheerios, just to help them work on developing those those fine motor skills, right? And then with the crawling, you want to make sure the crawl is even. So they're not just crawling to one side, but they're moving their hands and feet alternatively. And so that's going to be really important. Again, because of we'll talk a little about this with the back to sleep movement, you want to make sure those neck muscles are strong and they're also able to turn their neck and move their body symmetrically. You can get things like torticollis, which sometimes prevent the child. If they get a little stiffness in the muscle, they'll need some extra help with doing some stretching exercises to make sure that their crawl is even, their walk is even, and they're not going to be delayed in that sense. So they're crawling evenly. By 18 months, they're running. So I have an 18-month-old and you can't even keep up with them. So they should be running, moving, jumping, all that fun stuff. So at this age, before the 18-month well check, you want to talk to parents about safety. Safety is going to be a big thing that we're going to discuss in a little bit as well. So that child should be really active. Typically about 50 words on average is what an 18-month-old can say. Scribbling, so again, working on those fine motor skills, so making sure they have plenty of opportunity to use crayons, color on a piece of paper, and the coloring is going to be just scribbles, but making sure that they're practicing is really important. So educating parents about that. They do need to be supervised because they'll try to eat those crayons, but making sure that they're getting plenty of opportunity to strengthen those hand muscles. And then also they should be able to follow simple directions without your needing to point to things. So that's important too. And then by 2 to 3 years of age, really that language development kind of blossoms around 18 months to 2 to 3, right? So you see like 200 words on average, but around 2 years of age, the other thing that we really want to be mindful of are their social interactions. So around age 2 is typically when we'll see autism first present. And so we really want to ask questions like, how are they interacting with their peers? Are they making eye contact? You can also observe the child in your office. Are they able to make eye contact with you? Are they making eye contact with mom? Asking your screening questions before the visit or during the visit. Are they pointing to their own reflection in the mirror? Just making sure that they're socially and emotionally developing appropriately at this age is going to be really important as well. And then by preschool age, you see a lot of major improvement in those fine motor skills. So they're learning to write their letters, their numbers. You see a huge improvement in their cognitive abilities and their social skills. So again, preschool age, we're going to see how are they doing socially and emotionally. So they're going to be growing a lot in this sense, in this bucket, if you want to think about it as a bucket. And then school age, we're looking more at their academic milestones. But along the way, again, the milestones are something that help us as clinicians to make sure that these kids are growing and developing appropriately, right? So if there's a delay, we want to figure out why there's a delay. Now, every kid develops at their own rate, so they don't have to hit the milestones right on target, and they don't have to hit all the milestones right on target. There's going to be, some gray areas, and that's okay. But as long as they're progressing and they're progressing along with their peers, what you would expect for that age, that's what's appropriate. But if they're really not progressing the way they should be or hitting those milestones by that next milestone marker, then there should be some intervention to figure out what's going on. Some red flags to note are regression in those milestones, and you want to find out what the cause is. So if there is an explainable cause for that regression, it's not something to worry about. You can just kind of watch and wait and check back in on that patient in a few months. Some examples of that would be if there's a new sibling, right? You'll see the older sibling regress temporarily and start acting younger than their age. So that can be expected. But if there's no cause, or an explanation for the regression of the milestone, that's a huge red flag. And I want you to remember that for your boards too. They're going to be looking for that. And again, we talked about avoids eye contact, doesn't respond to name, doesn't point to objects. Again, you want to see how they're socially interacting with others. So screenings. Screenings, we talked about the milestones. These are just going to be like benchmark screenings that you're doing in the hospital and at every visit. Again, screenings, the reason why we do it is to catch things early and intervene early. So you want to make sure you understand why we're doing certain screenings as certain markers. One of the newborn screenings that I want to highlight is that bilirubin check. So with newborn screenings, every state is different, and you want to find out what kind of newborn screening they do in the hospital for your state. But bilirubin check is pretty universal, so is the hearing test. They also do the pulse ox just to make sure there's no congenital heart defects. The bilirubin screening, you should get familiar with the pathophysiology of jaundice because 3 out of 5 babies do have jaundice. So it's something that you're going to see whether you're in pediatric primary care or just talking to new parents. People might get a little scared about it, but understanding the pathophysiology and what to expect is going to be important for you. Hint, hint, pay attention to this part. We have a question coming up. So what is jaundice? It's too much bilirubin in baby's blood. So babies aren't born with a mature liver, right? So high levels of red blood cells in their body to help deliver oxygen to their body. So as those red blood cells break down, you get bilirubin as a byproduct. Oftentimes you'll see yellowing of the eyes and the skin. You'll first notice the eyes, the yellowing in the eyes, and that's also the last place to leave. And then the treatment typically is just feeding baby often. You have to let it wash out through the urine and the stool. It'll eventually wash out. So the other interventions you could do is exposure to sunlight or vitamin D drops. If you live in an area where you can't do that, say baby was born in the middle of winter, you can't take them outside and give them a little sun, you can use the vitamin D drops. And if it's really severe, sometimes they'll put baby under the phototherapy in the hospital and also recommend phototherapy once they're discharged home as well. And those are in severe cases. So again, it's going to be something you'll see in your outpatient setting. When that newborn comes to you for their newborn visit, you're going to assess the whole picture. So how is the patient doing? Is baby feeding well? Is baby gaining weight? What is their clinical presentation? How jaundiced do they look? And so that'll help you determine how often you're going to check those bilirubin levels. And there's an algorithm you can follow for that. But that'll give you an idea once you've looked at the overall picture, right? And so at that newborn screening, we're going to check length. That's their height. We're going to check their weight and their head circumference. So again, at every visit, we're going to do length, weight, head circumference up until a certain age. And the reason for that is because we plot these measurements on growth charts, and we want to make sure that baby is growing along their growth chart, and we're not seeing any drops in that growth chart or growth below a certain percentile. And we'll talk about that when we get to failure to thrive. And the reason for that is because we want to make sure that baby is growing appropriately and we do not need to intervene early, right? So these are all going to be, we're doing it multiple times to help with early detection. All right, so get your chat box open. Let's do a little practice question, see if you were paying attention. Which of the following contributes to the development of neonatal jaundice? So select all that apply. Is it A, increase in the breakdown of red blood cells? Is it B, breastfeeding? C, Rh positive neonate, Rh positive mother? Or D, decreased bilirubin production? So go ahead and put your answers in the chat. I know you were listening, so you're going to get this. Okay, you guys all got it. A and B. This was a little bit of a trick question. I was kind of being evil with this one. But A and B are correct. And why is that? So like we talked about, neonates have a higher level of red blood cells. And as those break down, you get bilirubin as the byproduct. So absolutely. But also, if we go back, so why breastfeeding? Didn't we talk about that being a treatment for getting rid of jaundice, flushing out that bilirubin? So how does that contribute to the development of neonatal jaundice? So breastfeeding, moms are breastfeeding a lot more often, but the baby is getting a smaller volume than formula-fed babies. So it takes a lot more to flush out that jaundice. So that actually does contribute to neonatal jaundice. So making sure you're educating the parents on breastfeeding often is going to be really important, right? And then that Rh positive neonate and Rh positive mother, there is no Rh incompatibility, so there's no hemolysis there, so it does not contribute to jaundice. And then D is also incorrect because jaundice is hyperbilirubinemia, right? That's a hard word to say. Not a decreased production of bilirubin. So awesome job, you guys. See, I knew you'd know it. All right, so moving on to screenings again, at your 1 month screening, what are we checking? Length, weight, head circumference. We're plotting it, we're looking at it on the growth chart, making sure baby's growing along their growth curve, right? That's really important. Also at the screening, their hips are developed, so you're gonna check for hip dysplasia, and you're gonna use those two signs that you learned, the Ortolani and the Barlow. And if you notice any hip dysplasia, you're gonna refer that out to look for, to see what kind of intervention is necessary. So again, all of these screenings are for prevention, right? So catch it early, prevent the complication, right? And so the vision screen is starting here, but it's going to check for any abnormalities by just looking at baby's response to the bright light in their eyes. So we're starting early to catch it early, right? That's the most important takeaway here. So again, 2, 4, 6 month, 12-month screening, you're going to be doing length, weight, head circumference, plotting it, checking those milestones, making sure they're growing along their growth curve, hitting those milestones appropriately. At the 12-month check, you're going to check for signs of anemia. You're going to do the hemoglobin hematocrit. You're also going to do a lead screening. Not all states require lead screening. I personally live in a state where it does not require lead screening, and yet I asked my pediatrician to still do it. Why? Because without lead screening, sometimes we have no idea the child has been exposed. And if they're constantly getting exposed to lead at high levels, it's damaging their nerve system, and at that point, it could be too late to intervene. So you want to catch it early, right? So we're going to screen at 12 months to help prevent those delays in growth and their cognitive and behavioral development, right? So going to do that at the 12-month mark. By 18 months, 2 years, 3 years, we're still doing the length, weight, head circumference at the 18 and 2-year mark. Around 3 years is when we switch. We no longer need to do the head circumference measurement. We switch to the blood pressure, and we're definitely screening vision and hearing at these screening markers too, right? Around the 3-year. It's kind of hard to screen 18-month-olds and 2-year-olds on the hearing and screening or in the vision. But preschoolers, here's our cute little preschooler, definitely getting ready to frolic around with friends at school and extracurricular activities. So at this visit, yes, we're doing length, weight. We talked about switching to that blood pressure instead of head circumference. We're also doing the vision and hearing screening. And so hearing, it's just going to be a noise where they raise their hand when they hear which ear it's in. That's the level of hearing screening we're doing. And for vision, of course, a lot of preschoolers, if not all preschoolers, most preschoolers don't know their letters quite that in depth yet. So we use shapes and images, and oftentimes they might get that wrong too because they might not know their shape. So that's typically what you're using for that vision screen. But our biggest focus, again, for this preschool age is their social emotional development. So how are they doing with their peers? How much of that social interaction are they getting? Do they go to school? Do they do extracurricular activities? And how are they interacting with those peers? Are they able to interact with those peers seamlessly? Is going to be important. So with the vaccinations, I'm not going to go over the whole vaccine schedule with you. That's something you can sit down and digest. What I want you to look at as you're looking at it, because it's a lot. If you haven't done pediatric nursing, it might not be second nature to you. So what I want you to look at are trends. What are you seeing? So here I'll point out like hepatitis B starts at birth, right? Everybody gets hepatitis B vaccine starting at birth. Hint, hint. Pay attention to that. And then again, second dose is around 2 months, third dose is by 6 months. So within their first year of life, they've already gotten 3 doses of hepatitis B vaccine, right? And then the other trend I wanted to point out on this slide is they're also getting their MMR, so measles, mumps, and rubella and varicella vaccine. First dose is at 12 months, second dose is 4 to 6 months. So the reason why trends are important is because the board is going to say you have a blank-year-old patient coming into your office, what vaccine are they due for? And so you can start to eliminate the questions that don't, the answers that don't make sense based on the trends. Like they should have already gotten their 3 doses of Hep B. So a 17-year-old's not getting another Hep B vaccine, right? So looking at trends is going to be really important. And then also typically the reason why they're getting the vaccines at those ages is because they're more susceptible to the virus at that point in time, right? So they're going to be more susceptible to measles, mumps, rubella, varicella within that age group. So that's also going to help you as you're looking to make your differential diagnosis in clinic and on the boards. So with that said, let's do a practice question that kind of highlights what I'm talking about. So get that chat box open for me. All right, so the Hep B vaccine is indicated for newborns in the first 24 hours of life in which scenario? So is it A, it is anticipated that the infant will be exposed to infected blood or bodily fluids. B, the mother is Hep B surface antigen negative. C, the infant is going to be formula fed. D, the mother is hepatitis B surface antigen positive. So go ahead and put your answers in that chat for me. Good. I see a lot of you participating. Good job, you guys. That's right. Yes. Okay. So if you said B, you are correct. So a mother with hepatitis, the mother's hepatitis B profile is always taken into account when we're looking at the hepatitis B vaccine, right? So in this particular scenario, if the mother is Hep B surface antigen negative, the vaccine series should be started within the first 24 hours. And then if we go to answer D, if the mother has a positive Hep B surface antigen test, this indicates an active Hep B infection, right? So the infant should be started on the Hep B vaccine series. So we still give the Hep B vaccine series, but then we also give the patient or the baby the hepatitis immunoglobulins as well within the first 12 hours, just prophylactically. So definitely always want to consider the mom's hepatitis B profile. And then also the reason why choice A is not correct is because the WHO recommends hepatitis B vaccines for all infants, regardless of exposure risk or not. So that's not the right answer. And then C, it doesn't matter if they're going to be formula or breastfed. Again, everyone's getting the Hep B vaccine. So good job. All right, another practice question. So there's that 17-year-old I mentioned, hint, hint. So a 17-year-old female presents to your clinic for an annual physical. After reviewing her chart, you realize she's due today for a vaccination. So assuming she is up to date on all childhood vaccinations, which vaccination would be required at this time? So is it A, her second MMR? Is it B, Tdap? Is it C, her meningococcal booster? So again, booster, that means it's her second one. Or D, second hepatitis B. Which answer is it? Yes, you all got it. See, you're paying attention, you're looking at the patterns, you're going to do great. So the choice is C. And why is that? Because this patient really should have gotten their first dose of meningococcal around ages 11 to 12. And this is their time for their booster right before they go off to college, where they'll be at more increased risk living in those dorms. So definitely this patient is due for her meningococcal booster. So why is measles, mumps, rubella not right? So right off the bat, you know that's not right because you know that she's up to date, right? She's up to date on all her childhood vaccines. So she got her first dose of MMR at 12 months old, and then her second dose at 4 to 6 years, right? And then Tdap also, that series is at ages 11 to 12. So you know that. And then she's really getting that every 10 years. Or 5 years if she's been exposed or if there's a risk. And then second, Hep B, we already talked about that, but you know that she's already getting 3 doses of Hep B within the first 6 months of life. So you know that that's not the right answer either. So good job. Awesome job, you guys. Okay. So safety considerations. Why is this important? So it's our job as primary care clinicians to make sure that we educate our families about safety concerns and we help prevent anything from happening, right? So what does that mean? So knowing statistically what are the most common causes of death, the slide is really depressing to me, but it's important because it'll help you kind of categorize what you need to focus on in that visit with that family, right? So between the ages of 0 to 12 months, suffocation is the most common cause. So we talk a lot about safe sleeping with those families, right? And we'll talk about that. Between the ages of 1 to 4, those early toddlers are really active. Drowning is the most common cause. So you want to really educate those parents about, do they have a pool safety, water safety around bath time, not leaving the child unattended in the bath. That's always a no. And then other culprits, falls, burns, accidental ingestion of medicine and household chemicals. So oftentimes people will just lock it up. But what I tell my patients is take it out of reach and lock it up, right? So go that extra step so that, because kids can be really smart, you know, especially those early toddlers, they love figuring out locks and gadgets and gears. And so they might be able to get into that medicine cabinet and the medicine looks like candy, you know, so you have to be really careful. And so prevention is going to be key with safety. So we want to talk about baby gates and locking cabinets, fences around the pool. The other thing I wanted to highlight is firearms. So definitely want to ask your patients, do they have firearms in the home and how do they store them? Do they have them locked away and out of reach? That's going to be really important, especially as these kids are getting more curious and growing. We want them to be curious and we want them to be adventurous, but we want to provide them with a safe environment, right? So making sure we're locking up any firearms. Also car safety. So car safety, the CDC does make general recommendations, but car safety guidelines and laws are specific to state. So you have to know the laws of your state, but in general, the guidelines have moved away from recommending age categories and they're more focused on weight and height for the car seat. So know that the rear is always the back seat's always the safest for kids when in an accident. So you always want to keep the kids in the back seat as long as possible. Rear facing is the safest. You do have to go to forward facing once they outgrow that car seat. That's typically around 40 pounds. And it depends on, again, on weight and length. So telling your patients to try to keep them in that rear facing as long as they can, as long as they're following the safety guidelines for their particular car seat. And then keeping those kids in boosters until they're old enough to wear regular seatbelts is going to be really important too. And that's going to be a little bit harder once the kids reach right around 11, 12, 13 years of age, because they're going to want to be in a regular seatbelt. You know, they're not going to want to be in a booster, but they still should be in a booster if they're not meeting the height requirements, right, for safety. And again, keeping them in the back seat at least till age 13 years of age is going to be important because those airbags are pretty hard once they deploy. So you'd want to make sure that those kids are in the back seat. This little picture about the chest clip placement, I have to be honest, as a new mom, I had to learn this not the hard way, thank God, not the hard way, but I also learned this. So you can take your car seat to certain centers where they'll make sure that it's clipped in right and kids are put in correctly. And so you want to make sure that chest clip placement is right over the sternum, because if that you did get in an accident, if it was over the abdomen, which is often where you'll see it on patients who don't know it needs to be further up, you can get some internal bleeding, right? So you want to make sure that those ribs are protecting those organs. So bring that chest clip up. The other thing I wanted to mention is the back to sleep. So we'll talk a little bit about this when we talk about SIDS in our next slide, but you want to make sure that there are no loose blankets in the crib, no crib bumpers. I know that was a fad for a little while, but no crib bumpers, no pillows, no blankets. Baby just needs to be in a little sleep sack and in crib by themselves on their back. So that's going to be really important. So let's talk about the newborn and infantile condition. So one that we've been mentioning is SIDS, that's sudden infant death syndrome. Unfortunately, they don't know the cause of SIDS. They know some risk factors that you can talk to your patients about and try to reduce risk factors, but we don't quite know the cause. And there are certain things we can do to help reduce those risks. So in the 90s, a campaign was started by a physician known as the Back to Sleep campaign, and it did decline the occurrence of SIDS by 50%. So that's huge. So if you were in my generation, we were all told to be put to sleep on our bellies. They found that that did increase the risk of SIDS. So now we're all flipping babies to the back. So you want to make sure babies are being put to sleep on their back. They're not overheating, so you don't want them in those extra blankets. You want to make sure you keep the room temperature nice and cool, because you don't want them to get into a really deep sleep, which is one of the things that they've been correlations that they've been finding with SIDS, that babies just get into a really deep sleep and they don't wake up. So you want to keep that room cool. And of course, you're checking for any cardiac dysfunction, so you're listening for murmurs. Mattresses firm, and breastfeeding does help reduce the risk of SIDS. They don't know why. Smoking increases the risk. So if mom was smoking while she was pregnant, or if there's a smoker in the house, that does increase the risk of SIDS. Bottle feeding is also a risk factor, and unvaccination. And then one thing, again, I want to emphasize, and you should emphasize with your families, is tummy time. So in tummy time, you are allowing the baby opportunity to strengthen those neck muscles. So if their neck muscles are getting stronger, if they do happen to roll over from their back to their belly, they're able to lift their head to take a breath, right? So tummy time is one of the biggest preventions in reducing the cause of SIDS. So please get your patients down on the ground with their babies for that tummy time. The babies hate it, but you gotta do it. All right, so fetal alcohol syndrome. So this is a result of the mother drinking alcohol during pregnancy. It's important to know that there's no amount of alcohol that's known to be safe to be consumed during pregnancy. So this is probably something that the OB will talk to the patients about, but if patients choose to drink while they're pregnant, they are putting their baby at risk for fetal alcohol syndrome. Again, it's a really gray area. Some providers are pretty relaxed about it. Some providers are pretty strict about it. But there is no amount that we know of yet that's deemed safe. So a blanket, if you want to, on the boards, you should say no alcohol during pregnancy to reduce the risk or prevent fetal alcohol syndrome. And so what is fetal alcohol syndrome? It's a congenital syndrome associated with excessive consumption of alcohol by the mother during pregnancy, and it's characterized by restrictions of mental development and physical growth, particularly of the skull and the face. So why is it important to know that pathophysiology? Because you're going to see distinctive facial features in these babies, right? So knowing the pathophysiology will help you remember what are you going to see in the clinic. So oftentimes you'll see small eyes, a thin upper lip, you're going to see short upward turned nose. So it's going to be distinct facial features for fetal alcohol syndrome. And again, you want to watch their heart, kidneys, and it can lead to behavioral issues down the line and learning disabilities down the line. So failure to thrive, we've kind of touched on this a little bit throughout the milestones and the screening, but what is failure to thrive? I want to make sure you understand it's not a diagnosis, but it's an observation. So the diagnosis is the underlying cause. You need to actually figure out what the underlying cause of the failure to thrive is and treat that, right? That's the only thing that's going to fix the failure to thrive. But basically, this baby is not growing along their growth curve. So the way we can define it is if they're growing below the fifth percentile for weight, weight is the most sensitive marker along the growth charts, or they can have a decrease in two major percentiles on the growth chart. So it doesn't have to be below the fifth, but maybe they've dropped in both length and weight, right? So that can also qualify them. What I would say is there are a lot of causes for failure to thrive. We put them in three different categories. One is inadequate caloric intake. So is baby getting enough nutrients? And so sometimes this can be breastfeeding issues. Maybe there's a poor latch, mom's having difficulty breastfeeding. So we want to help her out and try to figure that out by getting lactation consultant involved there. Sometimes it could be inadequate nutrition through formula. Maybe she's mixing the formula wrong, right? And the baby's not getting enough of the calories. Or maybe it's neglect, right? So maybe that mom is just not caring for that child. So there are three bucket categories. So inadequate caloric intake, malabsorption, you want to start thinking about allergies. Is there vomiting, diarrhea, blood in the stool? Is there a reason why that baby's not absorbing the nutrients? And then also increased caloric demand. So there are a lot of different conditions that can cause that as well. So the main takeaway for failure to thrive is that you have to find and address the underlying cause to help those babies return to their growth curve, or at least start growing and thriving on those growth charts, right? So that's going to be the most important thing for you, is catching that on their growth chart and intervening and investigating. So colic, what I want to mention about colic is I think all new moms and dads think their baby has colic. And so it's really hard, to tell new moms this baby's crying and crying. A certain amount of crying is normal, but with colic, it's long periods of inconsolable crying. So it's going to peak around 6 weeks. It typically resolves around 3 to 4 months. And it's more episodic, so it happens more common at nighttime. There is a criteria you can use to diagnose it. You just want to make sure that this isn't an otherwise healthy baby, right? Nothing else is going on. There's no acute sign of illness or infection. No imaging or labs need to be done. You just have to look at the overall picture, try to find the cause and try to address the cause. Oftentimes in the clinic, you'll see this baby really angry, red face, legs drawn up to their abdomen, tense abdomen. The cause can range anywhere from food allergies to reflux to just an underdeveloped GI system that you just have to wait out till they're a little older. What I like to do for these patients is get them to, if they're breastfeeding or even if they're formula feeding, get them over to lactation consultant, just because it does help with your differential diagnosis. They spend a full hour with the patient and often more frequent visits to really figure out what's going on for this baby and if we can help. And oftentimes eliminating allergens for moms, if they're breastfeeding, is going to be helpful. You could try to use anti-gas medication, though I never find those to be helpful, but basically giving the parents the support that they need, because this is a very frustrating and exhausting condition. And then also talking to parents about safety here. If they need a break, it's okay to leave baby in the crib in a safe area and walk away for 5-10 minutes to catch their breath, to take a minute to regroup, just because you do want to make sure you're also taking care of the parents in this scenario as well, so that they can care for the baby in a safe way, right? So this is often an exhausting condition for the whole family. So making sure you're helping support those parents through this difficult time is going to be important. Okay. So let's talk about our older babies and toddlers. So remember, in that vaccine schedule, we talked about some of those exanthems and happening at certain intervals, and that's why we do the vaccines at those intervals. So we're going to quickly go through this just for the sake of time, but I want you to get the key takeaways, okay? So measles, rubella, highly contagious. Hopefully you're not seeing measles, mumps, rubella, varicella in your patient population because of vaccination, but that's going to be your job too, to make sure you are vaccinating your population. There is a trend, now going towards delayed vaccination schedules or just not getting their kids vaccinated because parents are worried about autism. You need to help debunk that myth because there's no evidence of that, and you want to get your community safe by vaccinating everyone. So vaccination is going to be a key takeaway with this. With measles, typical viral symptoms, you're going to see cough, runny nose, conjunctivitis. On the exam, they'll probably mention Koplik spots on the inside of the cheek. In reality, if you're not seeing Koplik spots in the clinic, it does not exclude measles. So I want you to still have this on your differentials, even if you're not seeing the Koplik spots, okay? And then what's the management for this patient? Hydration, and then making sure that they're isolated so they're not spreading it to others in the community. And then once their symptoms are resolved, then they can go back to school and come out of isolation. But helping hydrate, keep these patients hydrated, and also using Tylenol for pain control is going to be important. But encouraging vaccinations, a key takeaway for this series when we're talking about measles, mumps, rubella, varicella. With rubella, again, what I want to highlight here is that this is not dangerous for the patient. It's not dangerous for the adult, but this is dangerous to the unborn child. So if you're suspecting rubella, it's highly contagious. You do want to get that serological testing done and confirm it on the IgM antibody test so that you can prevent any serious birth defects to that unborn child if in the community, right? So that's going to be really important. And again, same management. So hydration, Tylenol for symptom control, and encouraging the vaccination is going to be really important. With mumps, the typical hamster cheeks, because the key clinical features for mumps is the swelling of the salivary glands. You can also get testicular swelling. So for management for these patients, hydration is going to be really important because they're not going to want to swallow, right? So they're going to be really tender. They're going to be swollen here. So keeping those patients really well hydrated, it's going to be important. Giving them Tylenol for pain control. Also elevating and putting cool compresses on those testicular swelling is going to be helpful. But really, again, key takeaway is vaccination, right? Encouraging the vaccinations. And then same with varicella, also highly contagious, also preventable. So getting our population vaccinated, really important, 12 months, 4 to 6 years. This patient's going to be really uncomfortable with those vesicular rashes, going to be itchy, pruritic. It's going to start scabbing over and oozing over. So what I want you to focus on with management is keeping that skin intact and preventing those secondary bacterial infections. So clipping those nails short, try not to scratch, cool baths are going to be helpful. Acyclovir to help cut and reduce the duration of the outbreak is going to be really helpful. And isolation, again, just to prevent it from spreading in the community. Again, prevention with those vaccines. Okay, now on to autism. So with autism, it is now a spectrum disorder. It's both a neurological and developmental disorder and affects social, cognitive, and behavioral function. Autism is really difficult for families. We do not know the cause. There's a lot of guilt associated with it, with parents. I want you to support those families and those parents. Try to identify it early and know the warning signs. So if you're seeing those regressions in those milestones, always evaluate, be suspicious of this, see how they're doing socially with their peers. When they're younger, are they nonverbal? Are they not meeting their milestones? Lack of eye contact. So all those things that we talked about, the classical hypersensitivity to sound, right? And then you're not the one who's going to be making the diagnosis. You're going to refer to psychiatry and they're going to make the diagnosis based on the DSM-5 criteria. And then they'll come up with the management if they confirm that it is autism. Okay. School-age children and puberty. You guys are almost there. I promise you're doing great. So puberty, let's talk a little bit about that. So as a clinician, it's important for you to know the normal time frame of puberty so that you can help reassure patients and families, as well as catch things early. So again, prevention is key. So the average time frame for females in puberty is between ages 8 to 13. Typically, they'll have their first period around Tanner stages 4 to 5, so a little bit later as they're progressing. Males, normal time frame for puberty is between ages 9 to 14. So know these normal time frames, because if a patient comes in and they say, oh, she's starting to have body odor, she's showing, some breastfeeding, she's only 8 years old, reassuring that patient. Same thing at 13, maybe it starts then. Again, that's normal in females. She just might be on the later end, but it's normal. So understanding what's normal and what's abnormal is going to help you in the clinic and on your exams. Tanner staging is what we use in the clinic to help identify where they are along that timeline in puberty. So for females, we look at breast budding, we look at the genital area for hair growth. It's normal for patients to be between Tanner stages. So on the exam, you might see a question like, patient comes in, right breast is at a Tanner stage 2, left breast is at a Tanner stage 3. What should you tell this patient? And your choices might be refer to a specialist, reassure patient. So you want to understand that that is normal. You want to reassure that patient that that is a normal development. Oftentimes breasts will develop unevenly. So understanding normal Tanner stages and the normal variations is going to help you. And then with our boys, the Tanner staging is focused mostly on their genital area. So looking at scrotum size, looking at the hair and the penis and how it's developing is also going to help you with staging that male boy that comes in and see where they are along their puberty, within their puberty. And then also an exam you might see, or an exam question you might see is 14-year-old boy comes in, Tanner stage 3, has gynecomastia. Again, is this normal? Should you reassure? Should you refer? So again, oftentimes around Tanner stage 3, boys will have that extra tissue because of the hormones. So that will resolve over time as well. So knowing your normal and abnormal is going to be helpful. And then precocious puberty, again, knowing that timeline. So early sex characteristics of that female or male that's coming in and they've started to develop maybe the body odor, the girls are getting the breast budding before the age of 8. The males are starting to get some pubic hair. So you want to investigate that, figure out the causes, and you likely will have to refer to a specialist to really investigate that to figure out the hormonal causes. There's some genetic condition that's contributing to this. You might have to get a bone age, some hormone levels on physical exam, take a look to see if there are any features for genetic abnormalities, and then try to treat the underlying cause if there is treatment. Delayed puberty, same thing. So again, in a female at 13 years old, that's normal. But if she's older than that, so 14 years, male at 15 years. So you want to investigate that. Is there a genetic condition? Are there other causes? Nutritional deficiencies. So is this an athlete really suppressing her calories or his calories? And sometimes in those wrestlers. So figuring out the causes. Again, you'll likely have to refer to a specialist to do some more in-depth investigation with the hormone levels and the bone age and the physical exam, but treating the underlying causes often, and sometimes they might need estrogen or testosterone therapy, and we'll talk about that when we get to our genetic disorders. So let's practice. Get that chat box open. Which of the following is not a cause of secondary amenorrhea? So A, is it pregnancy? B, absence of menarche by age 14, C, excessive exercise, or D, stress? So again, secondary amenorrhea. Go ahead, put your answers in the chat for me. Yes, good job, you guys. Yes, thank you, Andrea. B, so the absence of menarche by age 15 is a cause of primary amenorrhea, not secondary, right? The other ones are all secondary: pregnancy, excessive exercise, stress. Those are all causes of secondary amenorrhea. So good job. All right, so genetic conditions. Turner syndrome. As we know, Turner syndrome is the absence of one X chromosome. So as patients get older, they might find amenorrhea, infertility are more common complications thanks to their ovarian failure. Some common findings that you might see on exam is short stature, the webbed necking, scoliosis. They might have the low hairline, small jaw, drooping eyes, the wide spacing of the nipples. So that physical exam is going to help with the diagnosis. But really, who's going to be making this diagnosis is your you're going to be referring to your specialist because they're going to have to confirm it on karyotyping, right? And then the treatment, these girls will probably need some estrogen replacement to help with that ovarian dysfunction, maybe some human growth hormone to help them try to grow, help them with that short stature. But this is probably going to be diagnosed and managed by a specialist. Klinefelter syndrome, so extra X chromosomes in male. So they can have one extra X or multiple extra X's, right? And so oftentimes clinical features, you're going to see tall stature, small testicular and penis size. And then if you check their testosterone level, it's going to be low testosterone levels, decreased body hair. So they're not producing enough testosterone because of those X chromosomes, right? And oftentimes with these patients, you're going to get a history of delayed speech in early childhood, low muscular tone, so they didn't crawl when they needed to, or they weren't walking or running. So you're going to get a lot of low muscular tone type of milestone markers that are delayed in their history. So again, who's diagnosing this? This is going to be your specialist, your geneticist, and you're also probably going to have these patients managed by an endocrinologist or some other type of specialist who will help them with their testosterone supplementation because they'll need daily testosterone supplementation, right? And then also helping with speech and physical therapy if they are showing some delays there. Fragile X syndrome. So this is an X-linked genetic disorder. That's why males are more susceptible, and it's the most common cause of intellectual disability just after Down syndrome. So you might see this in the clinic as well. Classic clinical features that you're going to see is that long face. You're going to see a prominent forehead and jaw with those large ears. Girls are going to have premature ovarian failure, so they're going to have irregular menses. And then boys are going to have larger than normal testicular size. So those are pretty classic features if you see it on the exam or in clinic. And then who's going to be diagnosing this? Again, your specialist with the karyotyping, and then the treatment. The treatment is pretty limited. There are a lot of clinical trials out there, so getting them over to genetic counseling just to see if they want to enroll in some clinical trials, but this will be managed by a specialist as well. Okay, quickly jumping to musculoskeletal conditions, and this is where we'll wrap up for the day. So scoliosis, this is something that we're all pretty familiar with. This is something you're going to screen at every visit. So that abnormal curvature in that spine, especially starting at ages 10. In our females, they're more at risk. So 10 to 18, you have two different types of scoliosis, early onset and idiopathic adolescent. That patient might be complaining of back pain. You might see some uneven shoulders and hips, changes in posture, right? Visible curvature, but sometimes it might not be visible at all. You want to definitely assess further. So I really like the Adams test because even with the really subtle scoliosis changes, you can see it on the Adams test. So having them put their hands together and touch their toes, then you can see that uneven curvature and that unevenness, right? In the back and the scapula there. Same here. If they're standing still, you'll see the unevenness. And how are you going to diagnose this? You're going to get an x-ray and then refer them out to the orthopedic specialist so they can assess the treatment plan or come up with a treatment plan for them, whether it's a brace or surgery or whatever is needed. And our last one, Osgood-Schlatter. So by definition, this is the inflammation of the patellar ligament of the tibial tuberosity. So this can occur during periods of rapid growth. So classic hallmark sign, you're going to have some tenderness below that kneecap right over the tibial tuberosity. You might have a lump there as well, and it's going to be unilateral knee pain. You can diagnose it on x-ray, and then the treatment is rest. So you want to make sure you help reduce that inflammation, rest that joint, use ice, NSAIDs, and then once that joint has rested and the inflammation has come down, then you can get that patient over to physical therapy to help re-strengthen that joint. All right, you guys did a great job. We got through a lot today, but I know that it's going to be helpful to you and you guys are going to do great on the boards. Before we get into the Q&A, go ahead and put your questions in the chat there for me, but I want to mention that we have over 1,500 questions in the QBank, so I put a couple of juicy ones in here today, but go to our QBank and you can just keep practicing those questions, right? Because you learn a lot from the rationale of those questions as well. So that's going to be really helpful, but every week we come up with new questions. We're over 1,500 now, so go ahead, get on that QBank and keep practicing, and you're going to do really well for the boards. We do have a 3-day live review coming up at the end of May, so registration's open. Please join us for that. we'd love to have you. You can go ahead and scan this QR code to check out all our free webinars coming up for the month of April and May. And then if you have any questions, you can go ahead and email us directly, and we're on social media. So we're here for you. You're going to do awesome, and you're going to be safe clinicians. And I'm excited to be part of this journey and helping you through, but I know you're all going to be great. So we hope to see you again soon, and let me know if you have any questions in that chat box. We have a few minutes left. So I do see a question about autism in there, and I saw Rachel was able to oh, thank you, Andrea. You're very welcome. Thank you for joining me and being so engaged. I really appreciate that. So with autism screening, who do you refer to? That's a really good question. So it depends. You can start with either psych or neurology, whoever you can get into first. It also depends on who's in your area, right? Like, so it's going to be really hard to get into to see that specialist, but both can diagnose. So that's a really good question. Yeah. All right, you guys, I'm going to go ahead and end the chat, but you have our contact information. Please don't hesitate to reach out to us, and we hope to see you next time. Thanks again for joining today.